everybody. We are going to pick up with blood pressure today. We're going to talk about the norms for blood pressure. Hopefully you did well on your quiz. So I'm going to start right here and just remind you guys to be sure that for testing purposes that'll be coming up, be sure that you are studying the vocabulary. There's a lot of vocabulary with this, so be sure you're studying it. Okay, so we're going to talk about blood pressure. Blood pressure is, and this is a definition you'll need to know, is the measure of the force that is required for blood to move down the artery wall. So it's the amount of pressure that blood puts on the artery walls to move through the body. Systolic blood pressure is the pressure that's exerted when the heart contracts. Diastolic is the pressure that the heart still maintains when it relaxes between beats. So the top number when you do a blood pressure, if somebody's blood pressure is 120/80, systolic would be the systolic portion of the blood pressure would be 120, and that's how hard the heart has to push to move the blood through the arteries. Systolic blood pressure is when the heart's contracting, and that would be the top number on the blood pressure. Diastolic would be the bottom number. So that would be how the pressure that the heart has still remains on the heart between beats. It is measured in millimeters of mercury, or mm/Hg. That's so like a normal blood pressure, for example, of 120/80 would be 120/80 millimeters of mercury, or mm/Hg. So that's how we document blood pressure: 120/80 and then millimeters of mercury. 120/80 is a normal blood pressure. So we have a range that are considered normal blood pressures. Be sure that you know those. The average adult systolic, or the contraction pressure for the heart, is between 100 and 140. The average adult diastolic, or the relaxed pressure of the heart, is 60 to 90. Anything greater than 140/90 is 140 systolic, or anything greater than 90 diastolic is considered hypertension. Anything less than 100/60 is considered hypotension. Hyper means elevated, hypo means below. So it'll be below normal or above normal. Be sure you know what hyper and hypotension are. Factors that affect blood pressure. Tons of things affect your blood pressure. Age affects your blood pressure. The older you get, the higher your blood pressure tends to get, because the heart wears out. And so it has to work harder and has to have more pressure to push that blood through the arteries. Also, your vessels start to wear out. So age has a big deal to do with it. For the most part, females have a lower blood pressure than males. Males tend to have more hypertension issues than females. I sometimes disagree with that, because as people age, it kind of evens out, and you tend to see just as many. Also, blood volume. So if you have lost blood, or you're dehydrated, it's going to make the blood pressure, severe bleeding, those changes in your blood volume, that decreases blood pressure. Stress will increase the heart rate, but it'll also increase your blood pressure. And it's part of the body's response to stress. It's some of the hormones that are released, and it increases heart rate and blood pressure. Pain increases blood pressure for sure. People that have chronic pain tend to have chronic hypertension as well. When we exercise, when we run, when we work out, if we're overweight or underweight, it affects your blood pressure. Generally, African American males tend to have the highest blood pressure of all people. African American persons tend to have higher blood pressure than Caucasians or Asians as well. Diet. So if you eat a lot of processed foods, if you eat out a lot, if you eat things with a lot of sodium, one of the things I see students eat a lot is ramen noodles. Ramen noodles are so bad for you. They have so much sodium in them. So if you have to eat those, try to eat them in moderation. Certain medications that we take increase or decrease blood pressure. One of the ones that decreases blood pressure, there are different calcium channel blockers, beta blockers, ARBs, angiotensin restricting medications. There are medications that also will increase blood pressure. Sometimes people, due to certain conditions, will have a low blood pressure. Also, your blood pressure changes from whether you're laying, sitting, or standing. So it will, when you're laying down, your blood pressure is normally lower than when you're sitting. And when you're standing, it's usually higher than when you sit. So that's why when you go to the doctor's office, they have you sit to take your blood pressure, because that's usually a good average between laying and standing. Now, that will definitely be affected if your fluid volume or your blood volume is low. We'll see an increase and like a drop in blood pressure and increase in heart rate a lot if your fluid volume is low when you change positions. Types of blood pressure cuffs. So there's the manual one that you guys are used to seeing. We no longer really have mercury thermometers in most facilities. We have tried to do away with those as much as possible. But we have the aneroid ones. Sometimes when you go to the doctor's office, there's the aneroid. The aneroid dial will be on the wall, and then the cuff will come from the wall. Sometimes it's just a cuff that's wrapped around your arm, and it has a cuff, a valve, and a bulb. They both have cups, valves, and bulbs. Just the dial is different. And like I said, we just tend to not have mercury anymore. It's not safe. If there was if there were to be a break. Using the blood pressure monitor, we are going to look at the blood pressure equipment. So we're not going to use the one in the middle really much anymore, because we really don't use mercury. We use the one on the right and the left. One is the dial. The other one will be the one that you see at the doctor's office. They both have the dial around it. Know that each long mark is a 10. It's in tens. And then the hash marks between the two longer marks each count as 2. So it would be, hang on one second, guys. Give me just a second. Okay, guys, I'm sorry. I had to answer my door. So let's get back to where we stopped. Once again, I apologize for that. Okay, so like I said, each of the small hash marks, the small lines, the shorter lines, those are 2. So it would be 80, 82, 84, 86 in those increments. And either dial they are all done that way. Guidelines for measuring blood pressure. We do not take a blood pressure on an arm that has an IV, a cast, a dialysis shunt, or if there's been a mastectomy on that side, if we possibly can. Also, if they have had, if they've been laying on that side or they've been leaning, there's been a lot of pressure on that side, we want to try not to do that, to use that arm, because it can change the flow of blood in the arm. We want to try to take a blood pressure sitting up as much as possible. If we can't measure it sitting up, we measure it laying down. Sometimes we have to measure it sitting, standing, or laying if the doctor wants that, but we document, and you always document whether it's sitting, standing, or laying. You generally, in an electronic health record, there will be a checkbox that says sitting, standing, or laying. You want to be sure you always mark that so that they know. We want to make sure that we use the right cuff. So if a cuff looks like, we want to make sure that the cuff is either a child's cuff, an adult small, an adult medium, an adult large. If someone does not have arms, we can check what's called you can use a thigh cuff, which would go on the upper part of the leg, and we would listen behind the knee for that and check that popliteal pulse and listen at the popliteal pulse for blood pressure. We want to, if we can, put it on bare skin, but if not, a very thin layer of clothing, a t-shirt. We want to make sure that the area where we listen for the blood pressure is exposed, which is why it's important to clean your stethoscope, and you need to clean your blood pressure equipment before you use it. We want to secure the blood pressure cuff snugly to the upper arm. We want to make sure that the room is quiet so that we can hear well. And if you don't hear blood pressure, you need to wait a couple minutes before you try it again, or switch arms. You don't want to repeatedly pump the bulb up continuously because it can actually cause some issues and make the blood pressure read normally. If you can't get a blood pressure or you can't hear it, you can ask another staff member, another nurse. You can ask a physician to recheck that blood pressure, but you need to make sure. Also, sometimes patients will have had surgery a long time ago on an arm, or maybe they had to have some kind of vascular procedure done. Ask the patient which arm they prefer to have their blood pressure taken on. It's absolutely fine. It's okay to ask them what their normal blood pressure is. If someone's normal blood pressure is 180 over 100, I'm going to need to make sure that I pump that up to about 220. Where if someone's normal blood pressure is 90 over 60, then I can pump that up to about 140, 160, 180 in that range and get a good blood pressure without hurting them, but still get a good blood pressure. The procedure: clean your stethoscope, earpieces, diaphragm with alcohol. You want to make sure that your blood pressure cuff is also clean. You want to locate the brachial pulse in the bend of the arm. You can use the stethoscope to make sure that you can hear it well. Then we're gonna put our cuff on appropriately above the elbow. You want to make sure that the arrow is pointing, because every blood pressure cuff will have an arrow on it that says artery. You want to make sure that is as close to or over the brachial artery as possible and fit it on there snugly. Place the diaphragm of the stethoscope where the brachial artery is. We want to locate the radial artery. Close the valve on the blood pressure cuff, turning it clockwise or to the right. Inflate the cuff until you can no longer feel the radial pulse, and then you inflate it about 30 millimeters of mercury above that. Generally, that's around 160 to 180. And then slowly deflate the cuff and listen for the blood pressure. The first number that you hear, that is your systolic blood pressure. So if the first time that you hear, not see the arm bounce, but the first time you hear a sound, that is the systolic blood pressure. You continue to deflate it until you stop hearing. At the last beat that you stop hearing the pulse is your diastolic. Your diastolic blood pressure. Once you get your systolic and your diastolic, you're gonna write it down. You're gonna document it. You're gonna take off the blood pressure cuff. You're gonna clean it. You're gonna clean your stethoscope and thank the patient. And then if they want to know what their blood pressure is, as long as it's okay with the doctor, you go ahead and tell them their blood pressure. We're going to take a second right here, and I'm going to let you watch someone take a blood pressure. Okay? So we'll watch someone taking a blood pressure. We're going to watch a couple of different ways. How to take it on the upper, the lower. Oops. I'm trying, guys. So this is with a standard adult blood pressure cuff.
This is a demonstration of the proper application of a standard upper arm cuff. Have the patient in a comfortable position. Legs uncrossed, back and arms supported. The middle of the cuff should be at the level of the heart at measurement. Have the patient relax for several minutes before taking the blood pressure. Measure the circumference of the upper arm midway between the elbow and shoulder to determine what size of upper arm cuff should be used. When cuff sizes overlap for a specified cuff, it is recommended to use the larger size cuff. Check the cuff, tubing, adapters, and hose for any signs of damage or wear. Replace if any signs of damage are found. Familiarize yourself with operating warnings. Inspect the arm for skin integrity. Do not place the cuff if the skin is not intact and if there are IV infusion lines, arterial monitoring, AV fistulas, or areas where circulation is compromised. It is always good clinical practice to document the site of the limb where the blood pressure is taken. Align the artery mark on the cuff over the patient's brachial artery. Wrap the cuff around the bicep, ensuring the index line falls between the range marks on the cuff. Ensure the cuff is snug enough to allow only 2 fingers to be inserted between the cuff and the patient's arm. Initiate a blood pressure using automated or manual blood pressure devices. Always refer to the instructions for use for complete information on the proper use and application of your blood pressure cuff.
Okay, that was just how to place the cuff. Now we're going to watch one on how to take a manual blood pressure cuff correctly. Then we're going to look at how to take one on the lower arm, and I'm sorry about the ad there, and how to take one on the leg.
Collins Hill with Consults in Hypertension in Wilmington, North Carolina. The question this evening is how to take a blood pressure measurement. If you've had your blood pressure measured in a doctor's office, it was probably taken by someone else, and they probably held a stethoscope over an artery. This takes a fair amount of training and is almost impossible to do on yourself. Fortunately now, we have electronic devices that can be used at home. Most of them can be purchased at drugstores and range anywhere from $30 to $100. In general, you want to avoid the wrist and finger machines because they're not quite as accurate. And when you have an arm cuff, you want to be sure that it fits you properly. A large arm and a small cuff will lead to an elevated blood pressure reading that you don't want. When you're taking your blood pressure, there's several things you want to be sure of. First of all, you don't want to have smoked for the last 30 minutes. Second of all, you want to sit quietly and comfortably with your back supported in a room that's not too cold and not too hot. If someone else is in the room, you shouldn't talk while you're taking your blood pressure. It's very important to hold your arm at the level of your heart if you want an accurate reading. And if you're not sure how to do that, think about saying the Pledge of Allegiance. When you place your hand over your heart, hold your other arm at a level that is the same, and that's the level that you want your heart to be, that you want your arm to be supported. Sometimes being seated and placing the arm on a tabletop or on the arm of a couch is at a good height. When you take your blood pressure, you want to place the cuff around your arm so that the middle of the part that inflates is right over your brachial artery. Your brachial artery basically goes through the underside of your arm. And then you want to place the cuff about an inch above where your arm bends. You hold your arm supported, hit the button, and the cuff will inflate. The cuff will slowly deflate as the numbers are found, and when it's done, the numbers will appear on the display. The top number is called the systolic blood pressure, and that is the pressure that's generated in your bloodstream when your heart does its maximum pump. When the heart relaxes and the blood is simply pooling in the vessels waiting for the next beat, that's the bottom number, or the diastolic. A normal blood pressure is less than 120 on the top and less than 80 on the bottom.
That's for someone who is under 60. So we're going to look at, that was one to show you how to use a manual cuff. And once again, I'm sorry. Let me get back to where we were.
Writing's not that easy.
Okay, so this will be a manual blood pressure here. It's going to take it a minute. This is actually a really good video.
Pressures often require that medical assistants, nurses, and physicians multitask while giving personal attention and quality care to every patient. Any measure of patient health that we take should be both trusted and accurate. What is the most important measure that we routinely check on our patients is also the most prone to error: blood pressure. We'd like you to review these following videos and note what is both right and wrong with their technique.
Okay, so you guys have learned all the right ways.
Hey, how are you? Good. Well, it looks like I'm going to be okay. Okay, want me to hold you? Yeah, maybe. Let me get my coffee down. Okay. Yeah, that's tight. Oh, it'll be all right. We'll be done in just a minute here. So how you been? I'm good. How are you? I'm good. How did you eat? It's good. What's normal blood pressure? You know, they like to see it lower than 120 over 80. Oh, okay. This was 180 over 60, so I'll let Dr. Koenig know so that she can address that when she comes and sees you. Okay, thank you. Have a good day. Thank you. You too.
So she sat down. She didn't ask the patient if she needed to go to the bathroom. The patient was drinking coffee. She wasn't able to hear it well, and the cuff was too small. So also the patient and her were talking the entire time. That was definitely some serious things wrong with that particular issue.
Small inaccuracies in blood pressure readings have significant consequences. It has been predicted that underestimating systolic blood pressure readings by 5 points of systolic blood pressure would cause a 25% increase in fatal strokes and heart attacks in these patients. Conversely, overestimating systolic blood pressure by 5 points would lead to inappropriate treatments with antihypertensive medications in up to 30 million Americans, causing increased risk of adverse drug events and unnecessary costs. Blood pressure reading inaccuracies commonly occur as a result of improper measurement techniques. How are you today? We're going to go right here in room number 1. Have you had any caffeine to drink in the last 30 minutes or so? No. Now, do you need to use the restroom before we get started? No. Okay, great. I'll have you go ahead and have a seat here in the chair for me. We'll let you sit and rest for a little while first. Okay. If you could take your arm out of your jacket, that would be great. And we'll get your blood pressure checked here. This cup's too big. I'm going to have to get that changed out really fast.
If the cup was too big, it would read it lower than it actually is.
Make sure it's at 0. Alright, I got 140 over 82. So it's just a little bit elevated, so Dr. Payne will probably want to recheck that again after she comes in to see you. We'll let you sit and rest for a little while first. Okay, thank you. Thank you.
So she did several of the things that she was supposed to do. She waited 5 minutes after the patient sat down. Generally, the medical assistant or the nurse will check your temperature and weigh you and then have you go sit in the room while they put those numbers in, and then come in after you've sat down for a few minutes and take your blood pressure. So they give you that opportunity to rest. She did have her take her sleeve off. She had to be quiet during the procedure. She was going to notify the physician that was a little elevated, and she did change out the cuff so that she could report it. She was sitting appropriately, feet on the floor, back supported, her arm was even with her heart. She used the right cuff, and she made sure it was in good working condition.
Accurate measurement and excellent treatment of high blood pressure.
We're going to stop that one there. One of the really big important things, like she said, if we are not checking a blood pressure appropriately, people can either not be treated or be treated in a way that they don't necessarily need treatment. So we want to be sure that when we check a blood pressure, we are checking it appropriately. So you guys have watched several. Now what you're going to see next is this is a normal old school flow chart for vital signs in the clinical setting. So you have an apical, a radial pulse, respiration. So if you did at 8 o'clock, you took their temperature and it was 99.4, then I would have put 99.4. I would have drawn a little dot there. If I'd have got a 68 apical pulse, I would have written that there. Oops, sorry. 68 apical pulse, I would have written there. I would have written the respirations of 12 there, and then what their blood pressure was there. We check an O2 sat often on patients as well. So used to, they would graph these for the doctor. They would actually draw lines for a whole shift from 8 to 8 to see how the patient's blood pressure and pulse were doing. This is one that is more, we don't really use any that are paper anymore, but we would go ahead and circle where those temps were. We would write pulse, respirations, all those kind of things. This is another similar chart. There's multiple ways. Pretty much now it's all electronic, and so you would put it there. I just put it in wherever it tells you to. Measuring weight and height, standing. So we wanted to, if it is all possible, we want to be able to measure height standing. That doesn't always happen, so sometimes we have to weigh people in their wheelchair. You have to know the weight of the wheelchair without the patient in it. When they're standing, you want to have them take any heavy objects out of their pockets. If they have on a coat, have them take off their coat, set their purse down. You can ask them if they're wearing heavy work boots. You might have them take off their boots so you get an accurate standing weight. Same thing when they're in the wheelchair. You want to make sure that they don't have things in their lap. You want to make sure that they don't have on really heavy shoes. If they have a jacket on, you want to help them off with that. You want to make sure they have the lightest amount of clothing on possible. There's also something called a lift scale for people who are completely bedbound, who can't sit or stand. There is it's called a Hoyer lift with a scale built into it, and you roll the patient onto what looks sort of like a tarp with hooks on each side, and you basically put the patient on that, hook the chains and the hooks into that, and you lower the bed as you raise the patient up. So you want to be sure that you're able to do that. To measure someone's height, you have two options. You can do it standing, and if they're standing, you want to make sure they don't have a heel on their shoe or anything like that. You'd ask them to take them off if they had a heel on their shoe. You want to make sure that if they have tall hair, kind of like I do, that you put the top of that when you measure the height, that you press down their hair so you get the appropriate height. Also, you can measure them based on their length. So if someone is bedbound, you can measure them head to foot. You want to make sure ask the patient if they need to go to the bathroom, because to be honest, if you need to urinate, it can make you weigh a pound or two more. You want to tell a patient if they need to weigh at home because they have congestive heart failure or some other kind of issues, that they need to weigh after the same time every day. I always used to try to tell patients, after you get up to go to the bathroom, first thing in the morning before you've eaten or drinking anything, and you go to the bathroom, go ahead and weigh then. They want to also use the same scales, and they need their scales to be on a hard, flat surface. They also want to make sure that the scale is on 0 if it's a dial, if it's an electronic scale, that it zeroes out before they actually get on it. Those are some of the most important things about measuring height and weight. Height and weight are very important. Height and weight help us calculate someone's BMI, their their BMI, their body mass index. So that is an important thing that is attached to a lot of physicians' payment. They check so many charts, and they want to make sure that you've calculated BMI. Now, one of the great things is you don't have to do that on paper and pencil anymore with a calculator. Most electronic health records now, if you put the height and weight in, it will automatically collect or calculate the BMI for you. But you have to be able to make sure that you check a height and weight. If you ask someone because the patient refuses to let you measure their height, or they refuse to take off their shoes, or whatever you need to do to get an accurate height, you need to say that is a stated height, not a measured height. You need to measure people's height at least twice a year. Physically measure it. It needs to be collected, not stated, at least twice a year. Things happen as we age, and we actually shrink a little bit. Our discs start to compress, and we do shrink over time as we age. Pain. We always, and this is a patient's right, to have their pain assessed. Things we want to ask related to pain. We want to ask them where their pain is. We want to ask them, and we need to understand that pain is subjective. So what is pain to me may not be painful at all to you, but what may be very painful to you may be minor pain to me. So pain is very subjective. The things that we have to ask a patient is, where on your body do you hurt? If they just say all over, say, can you show me with one finger where you hurt the most? It's really important to kids because kids will just say, I hurt. And they won't tell you where. Well, they can point to their head, they can point to their throat, they can point to their belly. So you want to ask them where they hurt. And then you want to ask them about the pain. So kids are a little harder than adults because usually adults can tell you it's an aching pain, it's a throbbing pain, it's just, I'm just sore. They can tell you that it's severe or it's sharp or it's shooting pain. The pain shoots from my hip to my heel. They can describe it. But for a kid, you may have to be a little more descriptive. Like you may have to show them there's a scale that shows faces and let them show you how bad it hurts wherever they're pointing to. There are different types of pain as well. Acute pain is something that comes on quickly but will go away. So like if there's someone's in a car accident and they break something, or after surgery, or they've had some kind of injury or disease process that causes pain, but it can resolve. And it may take 6 months to resolve, but it will go away. Chronic pain is pain that they have had for more than 6 months, and it can come and go, but they have it fairly routinely. Acute pain is sudden onset, and it will go away completely. Radiating pain is generally felt with tissue damage or near tissue damage. So that is basically when pain, you actually hurt in one area, but the pain will go down to another area. So sometimes when people have gallbladder issues, they'll hurt on the right side under their ribs, but it will radiate all the way back to their back. And they'll feel it in their upper right shoulder. So that would be a radiating pain. People who have sciatic pain, the pain may start just above the pelvis bone, but go all the way down the back of the leg, even into the heel. So that would be radiating pain. Phantom pain is what people feel when they lose a limb. So they'll feel like that maybe they've lost their leg below the knee. They'll actually feel pain in their calf, or in their foot will itch, or it will tingle, and there's nothing there. So that's what we consider phantom pain. That's pain in an area that is no longer there. Signs and symptoms, things we need to ask a patient. Where's the pain at? Like I said, when did it start and how long does it last? Ask them to rate their pain on a 0 to 10 scale. Once again, kiddos can't do this so well, so we actually have faces that you can let them point to about how bad it gets. One of them goes all the way from smiling to crying. And so you'll ask them which one of those faces is what it looks like when they hurt, what they look like when they hurt. Can they describe the pain? Can they tell me, back to the 0 to 10 scale. And you tell them 0 is no pain and 10 is the worst pain you can imagine. I used to tell patients 7 was childbirth. They just kind of look at me silly. But, 0 to 10, 10 is the worst pain they can possibly imagine. So you want them to kind of tell you where they fall on that scale. You want them to describe the pain using descriptive words like sharp, shooting, stabbing, aching, those kind of words. And you want to know what they were doing when it starts, what makes it worse, and what makes it better. So do they need medication to make it better, or do they need just to sit down for a little while and the pain resolves? You want to make sure, you want to check their vital signs when they're complaining of pain to see how it's affecting their blood pressure. If pain is pretty significant, generally their vital signs will be elevated with the exception of maybe temp, and over time it will actually go up a little. People will hurt and be nauseated. Their skin will be pale. They'll get clammy or sweaty, and they'll even vomit from pain being so severe. Also, you'll hear them groaning or crying. If pain is really severe, they'll be guarding the area of where pain is, where they don't want anybody to touch it. They won't be able to sit still. They'll be really cranky sometimes. Other things you'll see is people will be very flat, have a very flat affect, or we call it very stoic, which means that they kind of talk through clenched teeth. They'll kind of make faces but tell you it's not that bad. Wrinkling their forehead and scrunching up their face. So those are people we have to really watch, because sometimes they're hurting really bad, but they just won't tell you. And we have to document all of those things. All right, guys, that completes vital signs. You guys are actually going to start practicing them soon. So I will get back with you guys, and I'm going to make some videos with my students checking vital signs electronically and manually so that you can see that. All right, everybody, have a great day.